are a couple things I can really pinpoint that I thought was definitely beneficial. One was praying. Like I said, faith is a big part of my life. I really needed something else to kind of be an outlet at that time. And
Hi.
yeah. How's
Oh,
it going?
good. How are you?
Good, good.
Great. Thank you so much for joining, guys. We have Maria Weselyj here with us today. She is a neurosurgery PA. Thank you, Maria, for coming on.
Yeah, I'm excited for this platform. Thank you so much for having me.
Thank you. Thank you. So we always like to start off by knowing a little bit more about you, about your journey to becoming a PA, what you did before PA, your major, how you got patient care hours, and why you chose PA. Can you share a little bit more about that?
Sure. Yes, I get that question asked a lot. My journey was really interesting, and I'm sure of many others as well. For me, I actually was born in Ukraine and I immigrated at the age of 6. So I speak fluently in Ukrainian, English, and a little bit of Spanish and Polish as well. But ultimately, from a young age, I didn't really know if I was going to get into medicine at all. I actually wanted to be an FBI agent, and that quickly kind of turned. But I always knew I had a passion, I should say, and fascination for science. And it wasn't until college where I truly kind of focused in on exercise science. And that was my undergrad degree with a concentration of human performance. So I really cared about exercise physiology, how our body functions under stress. I was a lab researcher as well for triathletes and ultramarathon runners, and I really enjoyed doing that. Yeah. And I just didn't exactly know what I was going to do with that degree, but I also was a 4-year college basketball scholarship athlete, and I played on the women's team. So I was really into leadership, motivation, and just overall performance. So right after, I really dedicated a lot of my time to professional development basketball coaching for high school, college, and semi-professional level, as well as working for a basketball company that really encompassed all of those things. So while I was going in undergrad, I was getting my degree. I was a full-time student athlete, which was really important for me in terms of balancing my coursework and competition and research of the opponents and so forth. And I kind of, towards the end, after I graduated college, that's when I started to pursue the PA profession. And it was because I got injured my sophomore year of college, where I wasn't sure if it was going to be a career-ending injury, but I needed ankle surgery right away. At the time, I saw the PA for orthopedic surgery and I had no idea who she was. And I was giving her such a hard time. And I was like, I need to see the surgeon, this and that. And I was emotional. Yeah. And I had no idea what her role was at all, but she really explained it with much grace and education and advocated for the profession. And the more I got to know her, I mean, I was out for 10 months. So I really got close with her. And throughout those years on, I still wasn't sure if it was for me, but I was a medical assistant and EMT as well in the mix of my years. And then after I graduated, I took some summer courses and still coached basketball and traveled. And then I dedicated 3 years to mission work. So faith is a big part of my life. It's number one. So for me, I knew that was also important, of service. So just a combination of all these experiences that I've had, by the grace of God, it just really made sense for me to go into a profession that really encompasses a multitude of professions in one, and has that great flexibility that we all really strive for. So that's essentially how I got into truly being passionate for the PA profession. It took a lot of learning and research, but ultimately I'm really happy with the decision.
That's awesome. And first, I want to say, or want to ask, how's your family, or if you have family in Ukraine, how's everything going over there for you?
Yeah, thank you for asking. It's been a whirlwind. I have some cousins and aunts and uncles actually that live on the western side of Ukraine, and kind of where I was born. And my parents actually adopted me, so they're Ukrainian American. So I don't know my biological parents by any means, but my adoptive parents, they have family members, and they fled to Poland, I would say 2.5 months ago, kind of like I would say in the beginning of where a lot of it really took place, in the invasion, but they had to leave their uncles and brothers and sons behind to really fight with the war and everything that's going on there. And I can't really imagine, because they're moms and with kids being in a completely different country, trying to still upkeep with schooling and acclimated, but also knowing that, you know, there's children out there that don't have that same privilege. So right now they're safe, but definitely minimal conversation.
Right. And I pray for continued safety and protection for them too. I hope they stay well.
Thank you so much. I really appreciate that.
Thank you. So you have an incredible story. So I'd like to know now more about your going into the PA school, like how that application process was like. And I'm sure a lot of students want to know how it was like applying, especially, you know, now it's like we're at the height of the application cycle. What was that journey like for you?
Sure. I would say it was stressful in a sense where I was still trying to learn a lot about just the overall application process. I didn't have many resources at the time. I had Snapchat and it only had 3 filters at the time. And some girl that I was following had just posted it on her, like, a message to me that she was reading this book on how to get into PA school. And I was like, oh, I want to do that too. And so I read that book and it was the ultimate guide of getting in. And that was really it was like my minimal resource at the time. But ultimately, I did a lot of research on the programs, as I really encourage others to do the same. And I really just had to sit with myself and be like, well, what kind of provider do I want to be? What are some philosophical characteristics that I have, that they have, and kind of match really what I want out of a program to prepare me for and build the competence and so forth. So I initially applied my first cycle, and it was really a test run because, again, I didn't really know much about the process, but I was just excited to get out there. And I didn't get in any of the schools that I applied. It was about 6 schools at the time. And then the second cycle, I only applied to 4 schools. And I thought that was really important to me because I could really showcase more of, you know, my focus, my academics, a lot of the well-rounded type of attributes I had at the time for select smaller case of schools that I had chosen to apply to. And it was that year that I had landed interviews and a couple acceptances and ultimately decided on University of Bridgeport. And what I loved about that is it was close to home. It was financially smart in terms of programs and cost and all of that I had to really take in consideration. But it also really talked about integrative health, which is really important to me as well, and community service. I'm a big advocate for serving the community in any way. So I just felt it was the best fit. When I entered the program, that was a whole different story. I mean, I couldn't take the habits that I had in undergrad in the same way to take it into graduate studies. And the argument really is how much can you really prepare for that? And it's difficult, but ultimately I wasn't strong academically because I had poor study habits, but I knew as I was going through clinical year, I was really competent hands-on, and that was the kind of learner I was. So I encourage a lot of those that are watching here is really understand what kind of learner you are. And if you do better in study groups or just personal studying, really try to understand that now, because it's going to come into play when you're actually going through a very rigorous program in your didactic year and clinical year. So I really struggled. I was on academic probation my first semester. So that was a really big uphill battle, because once you fail another exam or a module, that's pretty much it, unless you can appeal. And I knew that that wasn't going to be the case for me because I'm intrinsically motivated, but I also had a lot of support. So when I went into my clinical year, I kept an open mind. I didn't really know exactly what I was going to major in terms of specialty, so to speak. But I loved every setting that I went to, and I learned the things that I did like about them and aspects of medicine that I didn't really see myself pursuing. And you'll learn that as well. So I also encourage an open mind, and it's not bad to have a fixed mindset on pediatrics if that's something you're passionate about, but it is important to really try to take as much as you can during your clinical year. So at that time, it was my general surgery rotation, and this was a rotation I was dreading ever since I even chose to become a PA. Like, even a thought, I was like, I don't know if I'm going to be good surgically or instrumentally. I have no idea. I love talking to patients. I can't do like one quick sentence reports. It's just too much for me, where I want to give more and they expect to give less, rightfully so. So I entered my first week, and it was scheduled in a way where you basically, as a student rotating, choose any cases for the day. And you just go in and you either first assist the surgeon themselves, or you pretty much just help out in any way and round on patients in the hospital. So once I finished my case that day, this is kind of where my career now really was solidified. I essentially looked on the OR schedule board, and I noticed there was a spine case going on. And I was like, wow, that's so interesting. I have no idea who the neurosurgeon is, and I'm not even sure how to pronounce this surgery name title. So I'm like, this is a lot going on. But I was like, something in me just really told me, hey, go in there, ask if you can observe. And it was already 45 minutes into the case. So I was also kind of apprehensive at that time, just because it wasn't at the beginning of the case. But I went with my gut. I walked in there, and I get in the OR room, and the neurosurgeon looks up at me and he's like, who are you? And I'm like, well, I'm a PA student with the University of Bridgeport. I would love to observe your case. And he pauses and he looks back and he's like, well, you're not going to see anything from where you're standing. So why don't you just go back out, scrub in, and stand next to me? So I was like, yes, of course. So I went, scrubbed in, stood next to him, and it was a laminectomy case. And I just learned a lot in that next 2 hours, so to speak. It was a laminectomy and discectomy case. And this neurosurgeon's been a neurosurgeon for 40 years. He comes from a very military background. He wasn't far from Harvey Cushing at the time in terms of learning from his residents. And I'm just standing next to someone that's been around this field for so long, that was willing to give me that opportunity. And at the end of that conversation, at the end of that procedure, or surgery rather, he told me, he's like, how serious are you about this profession? And I said, I'm serious enough to get my feet wet, and I'd love to learn more. And he says, well, why don't I mentor you for another 6 weeks for an elective rotation in neurosurgery? Call your program. You're already contracted with the hospital. Let's make it work. Wow. So I said, that is an excellent opportunity. I will call them. And sure enough, got set up for neurosurgery for the following 6 weeks after the general surgery rotation. And it completely solidified my passion, and it was challenging and rewarding. And in all ways, I was just so thankful that by the grace of God, he was able to mentor me. And he's never had a student in like 15 years really be someone that he was willing to teach and first assist. He hasn't been used to that. He doesn't have a PA himself. He's very much, like I said, military style, can do all the surgeries by himself. And I was just really grateful.
They're tough. So
yes. Yeah, so I was really grateful just for that. And it was towards the tail end of my clinical year, so I knew I was confident to apply. I applied to multiple jobs. I got a job that I thought was a great job, one of my dreams, but then we come back to my difficult time with academics and really digesting a lot of the material and learning all the aspects of medicine in such a short amount of time, that I had a job lined up ready for me right after I graduated for neurosurgery. And I took the pants and I failed my first time. And I was like, man, it was gut wrenching. I needed those 3 months to restudy everything, kind of get back on track, adjust my studying habits, adjust how I approach the questions. And it was really tough for me for those 3 months. That was the only thing that was standing away from, or between rather, me seeing my future patient as a certified PA. And I retook the exam and I blew it out of the water. And literally the next day, got a call from someone recommending me for neurosurgery, a job that I initially didn't want based on location. But I said, what the heck, I'll go in for this like informal interview. And I ended up going for the interview and just really connecting with the neurosurgeon I have now, and everything worked out. I got my license the day after I passed my exam. I got my public health license. Everything just somehow went into this beautifully, divinely calculated order. And now I'm at this amazing job that I literally can't brag more about, just because I'm so proud of really the environment I'm in, and it's safe, it's fostered, and it's great hours.
Girl, first, I want to say that like you've been so vulnerable and I love that. Thank you so much for that, because you're sharing a side of you that, students need to hear that, you're going to struggle in PA school. You might, fail your boards, which is difficult and hard to get through, but then you just take it over. You just have to have that grit and that, that resiliency to keep going. And it'll work out. Like I got emotional when you said all that, when you went from saying, oh, I was on academic probation, but then I graduated PA school, then I fell the pants, but then now I'm in this great neurosurgery position. Like I hope you all are all inspired, because I sure am. So thank you for that. Thank you.
Of course.
With that being said, I want to ask you, how did you change your studying? Because I think it's important for students to know, like, what did you do to help to pass, and not just, the pants, but PA school, like to get off academic probation and, move on to rotations and graduate PA school?
Sure. A couple things I can really pinpoint that I thought was definitely beneficial. One was praying. Like I said, faith is a big part of my life. I really needed something else to kind of be an outlet at that time. And I've always had a really good relationship with God. So for me was just really lifting that worry, and whatever someone believes in, it's really just allowing yourself to be vulnerable, allowing yourself to cry when you need to cry, allowing yourself to just talk it through, and really be on the positive side, like have a positive self-talk. But applicably, another thing that really helped me was creating, really getting myself into a study group that I really trusted. And it wasn't a big one. And sometimes in PA school, you will have big study groups for said classes like anatomy and physiology, where everyone kind of needs to understand. But if you find your core three, you stick with your core three, and you will really learn from each other, and they might pick up something in the notes that you didn't have. And really to be vulnerable and allow that to kind of cater your new study habit, but also preparing a lot more. I was usually one that would look at something and I was like, oh, I think I know it. But to really understand what the question's asking, it wasn't so much of the material that was given that I didn't understand. It was, well, how do you apply that material into your questioning format of tests? And that really is a lot of repetition. It's using question banks that are out there. It's allowing your friends to really quiz you and not ask silly basic questions that everyone should have a slam dunk on. It's really tough questions where there's no multiple choice. They're really asking you, what's the innervation of this muscle by what nerve? It's not like, here are your options. And then also when you're answering questions on a test or a pre-test, it's really looking at the STEM question. Like, what is it asking before you even read the prompt? Is it asking about a medical intervention? Is it asking about a diagnostic intervention? And the sooner you get to have a routine for every question, the faster your time and test taking will be. But also you understand, like, okay, I'm trying to answer a medical intervention question. Therefore, I need to start thinking about medications that we learned. And then really pinpointing some of the words and verbiage that we've heard multiple times. It's just described in a different way, and really looking at your options and doing that process of elimination. And I didn't have any of those techniques going in, but the more you go through your schooling, the quicker, by the second, third semester, you should really get a good routine down. And if you don't, utilize your academic services, utilize your clinical coordinators. They're there for a reason. My program was an open door policy. They were really tough. Like, they did not waver, but they were really open to being like, hey, let's sit down. Let's talk about the concepts you keep getting wrong. Let's figure out how else we can help you understand this idea when it comes to nephrotic syndrome versus nephritic syndrome. What are some things that you need to know the differences on, because those are going to be the ones that are going to be tested, and you'll see that a lot more than something that's really rare. So I thought that was really helpful. So hopefully that helps the people here that are watching in some capacity.
Yes, definitely, definitely. So a student wants to know, did you struggle academically during undergrad?
No, I didn't. Only because I really only knew, like, exercise science was something I was really passionate about. And I knew a lot about musculoskeletal, nervous system, and most of my classes were geared towards that. The only classes I really struggled with was organic chemistry for sure. I still have PTSD from that, and like physics course, that was really, really tough for me to conceptualize. But when you're in PA school, there's a multitude of thousands of medical conditions you need to know, and whether you're strong in it or not, you will be exposed. And that's just part of the process. It's nothing to get discouraged about, but some people are really good in women's health, and other people struggle with the pathophysiology of everything that goes on in a woman's body when things are happening hormonally, and delivery and emergency situations. It's a lot more difficult than maybe your orthopedic exam.
Yeah, ortho is not my forte. That's not my thing. Like anything ortho, I know for sure I'm not good at. So you're definitely right. Thank you so much for that. So we are going to move on to discuss more about your job as a neurosurgery PA. Can you tell us more about like a day in the life of a neurosurgery PA, or at least the work that you do from when you clock in to when you clock out, how your hours are like, your surgery days, if you're ever on call? Can you just share everything with us?
Sure. I personally think I have a very unique job flexibility than most of my colleagues that are in neurosurgery. And that just has a lot to do with maybe the hospital that they're at or the surgeon that they work with. But for me, I absolutely love my job in a way where it's 4 10-hour shifts a week. And usually my mornings start with rounding at 7 a.m., pretty much on patients that just had surgery with us, that I was in the OR with, first assisting the neurosurgeon, or patients that kind of just got admitted. Maybe they had more of an emergency situation where we haven't even planned for surgery a month prior, but now their symptoms progressed, and they're in the hospital that we need to check on and do a lot of work for before we even consider surgery. Or they're just patients that have been there for a few days, and now we're just really kind of to the tail end of their discharge, just formulating more of kind of how is that going to go. So that's usually around 7 a.m. to about 8 a.m. You get all your notes done. I have set template notes on everything to kind of just quicken the process, because I only work with one neurosurgeon because I'm both outpatient, inpatient care. So I work in the hospital, but I also work in the clinic setting. I have 2 outpatient clinic settings. One of them is right across the street from the hospital, and that's pretty much all of our spine patients. Our practice is typically 60% spine, 40% brain. And then I have another clinic that I go to that's about another, I would say 15, 20 minutes from the hospital. And that's strictly for our epilepsy patients and brain patients with shunts and tumors. They pretty much go over there. And we have a 16 inpatient PA team. So there's 16 PAs just for the inpatient side of the hospital, which you don't see a lot. So I'm at a hospital for our neurosurgery department is PA heavy. We only have 1 resident rotating among 2 hospital affiliations, and then the rest are PAs. So they're more in charge of working with multiple neurosurgeons. Whereas for me, I only have to focus on what my neurosurgeon wants in the way of the protocol, and the way that he's very eclectic. There's not many surgeries that we do over and over again. It's always something new. So I personally like that. I'm very adaptable. I really like to learn. I want to know, how do you place this particular electrodes here for an epilepsy case to pretty much prevent future seizures for people that have had debilitating seizures for like majority of their life, and they have kids and so forth, versus how do you do this particular spine case and what does that look like? So I like the clinic side because I don't have to work weekends, nights, or holidays. That's one of the big perks and reasons why I chose that ultimately following that interview. And another reason is I get to see the patient through and through. So from the moment they come in as a new patient in the clinic setting to the moment if surgery is warranted or offered ultimately after conservative measures, I get to be in the OR with them and I get to see the case and understand. So when they come in for my post-operative visit that I have for them, if they have questions, I actually know what was going on, or if even if there were sutures or staples, or how much length did we take off the spine. These are all really important things because my favorite part of medicine is patient education. I will always take my time. In neurosurgery, we have the privilege to have visits be 45 minutes to an hour, which is great because it does rely on that in terms of the complexity of our nervous system. It governs how you breathe, how you think, how you sleep, how you walk. Everything is governing by the nervous system. And so I really take my time on showing models, showing clinical studies, if they have questions on that. I never shy away, and I'm really big on understanding who's in front of me. If I have a patient that's Native American, most likely I'm already expecting, even before they walk in the room, that they've tried everything else that they believe in their culture, and they're most likely going to be very symptomatic on a physical exam, almost to an emergent surgery situation, versus someone that may not have that culture per se, and they might be all about allopathic medication, and they tried all these things and now they need surgery. Or the way that they even sit in the office, you look at their posture, you look if they're kind of away from the chair, you look at if they're tracking you as soon as you walk in the room, you're seeing, hey, like, can they even make eye contact with you? And that takes time to learn. But these are all things that we look at even before I think of doing a cranial nerve exam, even before I think of, hey, maybe they just have a disc herniation, or maybe they have some weakness in their upper left arm because of just how they're sitting, right? So clinical history is important, but the physical exam is just as important with diagnostics. I don't treat images. I have the same philosophy as my neurosurgeon. We treat the patient. Just because something may not be on the image doesn't mean that this person isn't actually dealing with how severe their symptoms are.
Right. Thank you so much for that. So can you tell us, it sounds like epilepsy is a major, disorder that you see. Can you tell us other common ones for spine versus the brain?
Sure. I actually have a presentation of a case, and it really does encompass a lot of the different types of things you'll see in neurosurgery.
Awesome. So we're going to answer just a few more questions, guys, and then move on to the case study. What courses in undergrad were helpful for PA school?
I believe biochemistry was really important. I also want to say that the chemistry classes were important, chemistry 1, 2, especially when you're dealing with acid disorders. You're dealing with kind of understanding what is chemically going on in a person's body with certain diseases that you'll learn foundationally. Anatomy and physiology, for sure, I think is just an overall excellent foundational course because that caters to the why behind the what when you're doing a physical exam. You're not just doing a physical exam to just kind of go through your routine from head to toe. You're actually doing it because you're thinking of like, well, why am I only doing a focused exam for this particular differential diagnosis you have in your head? And you will be prepared after your physical exam courses in PA school. So I would say those 3 things truly always acted as a foundation, no matter what module you took in your schooling.
Perfect. Thank you so much.
Mm-hmm.
And how did you, transition? How was the transition from being an undergrad to, working in that, learning curve and getting comfortable working as a neurosurgery PA?
So my transition from being a PA student to the field, yeah.
Your specialty.
Yeah, I think what really helped was the elective neurosurgery I had. I do have some colleagues that never did one, so it's not like you have to have an elective in the career that you end up in. But for me, especially in neurosurgery, I needed to see a lot of that stuff before I kind of dove in for this career, just because conceptually, and there's a lot going on that I really needed to learn. But ultimately, I'm 7 months in as a PA, so I'm not even a year in, but I really feel every day you learn something. And the most important takeaway is don't ever be shy to ask for help. That's even now as a pre-PA student, always ask for help, always have the ability to kind of humble yourself, because medicine will do that, but also in a way where, listen, there's a reason why we're in a collaborative team environment as a profession as a whole. And it's important to be able to bounce off ideas so that you don't miss something important. Or I've had moments where I've told my neurosurgeon, hey, did you find out that the patient had this particular history? He just shared that with me during my rounds. And it was because I asked a particular question that my neurosurgeon didn't ask. And it's not that, he wasn't looking for it or it was his fault, but it was just that one patient history tip that the patient gave that completely changed our entire decision making. And it saved him from having to lie flat for 2 months thinking he had a cerebral spinal fluid leak somewhere that we couldn't see on imaging. So that one little history that he told us that happened about 8 months prior to even the surgery that we had with him completely changed his course. And again, it was just the time that I took with him, but it was also just the foundation of PA school. You won't lose it when you transition to becoming a provider. I think the big transition that you have to make is just how much information is still being thrown at you, but also learning when to refer, especially if you're in a specialty, when to kind of admit someone, what's the disposition. Those things you learn on the job, and just how do you put your first medication order. That was like crazy to me, because I was like, oh, this is really it, like strap in. But ultimately you have that foundation, so you know more than you think.
Yes, thank you. So last question is, before we go to the case study, is can you share again what you did for patient care hours and how did it help you in PA school and the work you do now, if at all?
Sure. So the patient care hours I had was medical assisting. That was interesting. Briefly, I went to an internal medicine clinic the next town over from me. I was from a very small country town. We had like 2 traffic lights. And I went to the next town and I asked the doctor, I said, hey, I'm really considering the medical field. And at the time, I still didn't know if I wanted to be a PA, but I just told her, I was like, I would love to just learn hands-on of what a medical assistant does. I don't have a license. I didn't go to school, nothing like that for that profession, but I would love to learn. And her answer immediately was no. So I said, okay. So then I went back 3 days later and I did the whole spiel again. And she said no. So I said, okay. So I waited 2 weeks later. I went back and she finally said, okay, I'll take you on. I'll have one of my medical assistants teach you all the outside of kind of what the preliminary things you do, EKG, blood pressure, looking at urine studies. What does this mean? So she's like, but it's going to be volunteer. I'm not going to pay you. And she's an old school doctor. She was about to retire. I said, I'll take it. So I did 8 hours every day, volunteer for 3 months. And then I finally was like, do you mind like maybe paying me now that I'm here 3 months, I'm learning a lot? And she's like, yeah, sure, but at the lowest rate. I said, I'll take it. So after having a whole year's worth of medical assisting under my belt, just based on really persistence, which I think is very important to have as a PA professional, but ultimately even now as a pre-PA student, from the moment you decide to when you continue on in your career, that never should hold you back. I think it's only making you become more resilient. It's also allowing yourself to get yourself out there in front of people. And then the EMT thing I just did on a weekend course for it was an 8-week course every weekend. Even after all my kickboxing instructing courses I was instructing for, and like school at night, coaching during the day, I just wore many uniforms. And that's what I use as my personal statement. I was like, I'm a person that wears a lot of uniforms. And then I would just list them all. But that's how my life was. It was very hectic and filled with persistence. And so pretty much EMT, medical assisting, and being a neurobehavioral specialist, that I also got by really just networking, inadvertently, not trying to get somewhere, but it just happened. I was coaching one of the parents' daughters, and she's like, hey, you've been in the medical field in some capacity. Do you mind going for an interview for a neurobehavioral specialist? And I was like, I don't even know what that is. But she's like, oh, you deal with patients with traumatic brain injury and strokes, and you're on a unit and you're dealing with behavioral and de-escalation. And I was like, okay. So I just went and it worked out, and I stayed there for another year and I got all my hours. And I think also that one was a big, looking back retrospectively, it was a great foundation for my career now.
Definitely. Thank you so much. And I love how tenacious you are. I'm just loving it. Like your determination. It's amazing and very inspiring. I'm sure the students are loving it as well and learning so much from you. Thank you.
Thank you.
So
they're all so nice.
Thank you. So we are going to let you take the floor and present the case study. You should be able to share your screen and get the case study.
All right, so this is a case review. This wasn't necessarily through my job specifically. We've done so many cases that I don't even know if this was from my job or from one of my elective rotations at the time. I had to do a couple of these for our program, but this was a really good one, and it still to this day sticks out to me. So here we go. This is Harvey Cushing at the top right. He's pretty much the father of neurosurgery. Fun fact, if y'all haven't known that. But really, really innovative in many ways. So some of the conditions and treatments that we commonly see is you have two categories, neurovascular and spine. And in neurovascular, you can kind of read what we typically see on a daily basis, coming from like aneurysms to different type of brain bleeds, which you do learn in your didactic phase of year, brain tumors, glioblastoma multiforme, meningiomas, astrocytomas, the list goes on. Cerebral aneurysms, cerebral palsies, trigeminal neuralgia is a big one that we actually do commonly see. Head injuries, head trauma, hydrocephalus is another common, I would say, condition that we see where we kind of decide if we need to place a shunt or not. And any type of, again, really neuro-oncology and epilepsy as well, we deal heavily with. And then on the spine side, it varies with cervical spinal disorders like degenerative changes, osteoarthritis, osteoporosis, spinal decompression surgeries that we do where we really just decompress where the nerve may be pinched or the bone or the actual disc itself is causing some compression on the nerves. And then stereotactic neurosurgery as well. The list goes on. It's very vast. I probably haven't even mentioned even half of the stuff we do as well, with different stimulators that we put in, batteries, all of that. And then some keys to consider when you're pursuing neurosurgery or any type of neurology-based specialty. It's always important to observe a patient's gait. We've talked about that earlier. Even before they walk in the room, really assess how someone's walking. It's going to tell you a lot about what might be going on in their life and maybe why they're seeing you in the first place, not just because they were referred to you, but they actually have something going on neurologically. Or sometimes when you're doing a physical exam, the three things that we always have to differentiate from is this rheumatologic? Is this related to orthopedics? Or is this actually a neurosurgery situation? So again, knowing your anatomy and physiology is very important, and understanding nerve distributions, especially how they function. So this is excellent to know. You will learn this in PA school as well. Primarily this chart you'll learn in PA school, but this is an extension of that. So it's pretty much a body map. And I swear when I go to the grocery store or when I'm with my friends, sometimes I'm just like looking at a person and I just know this map at the back of my hand, because these are where all the nerves are supplying certain muscles. So C is for cervical, L is for lumbar, and you also have thoracic, which is really on your torso down. So as soon as you really understand the map and where the nerves are coming from, you'll understand the distribution. And then understand how to get a good full history and interpret diagnostic imaging, which will be important. And then, of course, knowing how the lobes function and what you're looking for, again, on the physical exam, because it's only just going to support your decision making. So this is a case study, and I had this patient myself that I was rounding on. This patient, her chief complaint is, I can't feel anything below my neck. So that's pretty much the first thing that I get on my rounding chart. And I was like, wow, this could be anything, maybe emergent. So this was the HPI. So the history, like what happened? How did she get here? So she's a 66-year-old right-handed female. It is important to know if they're right-handed or left-handed, just the way the brain functions as well, with a past medical history of COPD, hypertension, alcohol use, tobacco use, anxiety, and depression. She was brought to the ED by EMS 5 days ago for generalized weakness. So this was a consult that I was doing. So patient reports falling forward the night before at 3 a.m. under the influence of alcohol, striking her left forehead and hyperextending her neck. So she basically went forward and then back, causing immediate neck pain, but no loss of consciousness, which also is very important to know. That kind of plays into your GCS for those that are EMT, MA related professions and a multitude of others. She states that she felt immediate numbness of her entire lower body and could not move. She stayed lying on the floor for 5 hours after falling. So imagine she fell and she's been on the floor for 5 hours after she just hit her head. Super important. And she was intoxicated. She could not get up until she was assisted by her roommate onto the couch. Patient reported having pain in the right occipital area, which is in the back, and bilateral forehead region in the front, both sides, and took Motrin and Tylenol with no relief. CT head without IV contrast, plus a cervical neck x-ray and CT cervical spine in the ED were unremarkable at the time. Patient was admitted to the medical floor for further evaluation. On hospital day 5 is when I went to consult. So patient complained of bilateral upper extremity greater than lower extremity weakness. So her upper extremity definitely was greater of deficit. She had paresthesias down her right arm. So kind of that numbness, tingling, and lower body numbness from approximately T2 down. So think kind of like your sternum area all the way down. She denied bowel or bladder incontinence, which is important to always ask and assess. There's a few nerve disorders that we really look for that is emergent. You also learn that in PA school. It's a do not miss. On hospital day 6, neurosurgery was consulted, which was me. And she stated, I can't feel anything below my neck. So she complained of neck pain, persistent quadriparesis with a diminished upper thoracic sensory level and shallow breathing, but denied nausea, vomiting, blurry vision, double vision, confusion, headache, and bladder or bowel. That's kind of how you orchestrate your HPI. And then past medical history, we already talked about some things that she had. You should think of COPD as important, hypertension for sure, asthma. Why is this important? Because if this person needs to go to surgery, you need to understand, are they going to able to tolerate the surgery? Are they going to make it out alive? How long can they be under anesthesia, so forth? And then tobacco use, if you're doing a fusion, is that going to inhibit bone growth? Then for surgical history, she only had one in particular, not so pertinent to this case. And social history, 15-pack year smoking history, drinks 3 to 5 glasses of wine a day, which is excessive. You'll learn about the screening and kind of what questions to ask at that time. And then you just go over the current medications and allergies, and you'll learn what to recognize in the medications. It's called medication reconciliation. Really important before, again, you take someone to surgery or how you treat them after. Review of systems is basically going from head to toe. You'll learn that in physical exam. For her, what was positive is shortness of breath and wheezing. That could be really secondary to her COPD, asthma history, smoking history, all of that. And then on the MSK, she had for sure neck pain, tenderness, neck stiffness. She didn't really have muscle aches. And she didn't have back pain. And then neurologically, she did have tremors. That could be a mixture of things, of the fact that she was intoxicated. Maybe she's going through withdrawal. That's another thing you can consider for sure. And then weakness, numbness, and headache. So those are the important things. That's why I highlighted them in red. Everything else was within normal limits or negative. Then the physical exam, always look at vitals. It tells a lot about a person, especially the ABCs, airway, breathing, circulation, that kind of thing. Their general appearance. Well, what was she doing at the time I consulted her on day 5 of her hospital stay? She was shallow breathing and had a hoarse voice, but talking in full sentences. She had dysmetria, which is the finger to nose test. So it showed no ataxia, but it was slow. So she could still touch her nose and touch my finger where it needed to, but it was very delayed, very delayed. And then the positive Hoffman sign bilaterally was also very important on the physical exam, which is pretty much you flick the patient's middle finger, ring finger, and the pointer and thumb. They will involuntary pretty much just come together. It kind of looks like this. So that was really important to note. As far as her gait, again, we're looking at how they're walking, you're assessing. Antalgic means she was walking with pain. She had poor balance, and then you check all their motor strength. She definitely had weakness in her upper extremity, like we talked about before, greater than her lower extremity. And then in terms of the sensory exam, where you can use the instrument to check the thoracic level, she had a diminished sensory at T2-3 bilaterally, both sides. So again, chest down typically. And then for deep tendon reflexes, they were there, both sides, just a little bit more hyper-reflexive. Again, another sign of kind of the differential diagnosis we'll get into next. And she also had a Babinski sign that was present in her left foot. So differential diagnosis, this is really huge. You'll learn this in correlative medicine and didactic year. This is where you kind of put everything together, usually your second, third semester. You formulate, well, what could it be and what it could not be. So you rule in and you rule out in medicine. Don't forget the rule in and rule out part. So for her, my top was cervical spinal cord compression. You can read why that was. And then my second was traumatic cervical epidural hematoma with cord compression. So still cord compression. There's something going on with the spinal cord injury. And then TBI concussion, just due to the mechanism of action. And then I support, well, why could it be least likely on the list? And why is it most suggestive that it was a cervical spinal cord compression of some sort, of some etiology? Radiculopathy is important because that's just the distribution of the nerve pain, which is based on the mapping that I showed you. Even before they kind of tell you exactly their symptoms, you should already be thinking of that. And then different from myelopathy, which in that case is symptoms that appear in your abnormal reflex tests and just things that is really the silent killer is the cord compression. So a lot of times some people only have cervical myelopathy and they don't have radiculopathy. So they don't even know that there's a silent compression on their spinal cord happening until we assess them on a physical exam and we notice, hey, let's do imaging on your spine because you have some positive symptoms. So they won't have pain typically. She had both. So what do you do when you see all of this? You then go into your diagnostic planning. So what I had to do was just quickly think of orders of labs that I would do. In this case, a CBC without differential, EKG, CMP, PTINR, your anticoagulation things, tests, I should say, studies, and type and screen and COVID-19 swab at the time. Again, these are really pretty much preliminary if you're thinking of an emergent surgery. You need to have all these labs ordered prior to actually getting cleared from medicine so that you can do the surgery. And what images did I order? I ordered a chest x-ray at the time. Again, it was all in height of COVID as well, still is a protocol, but also just to check everything out. She has a history of COPD and a multitude of things. And then MRI cervical spine without the IV contrast. So we can actually really see what's going on at the spine level, considering everything else at the ED 5 days prior was unremarkable. And then we have results of the diagnostic plan. So these were her results. All were within the reference range, the normal limits that we would look at. Same thing, the CMP really takes into consideration your liver enzymes, your kidney function. And then her chest x-ray was here. Heart was slightly enlarged. She had prominent hilar vessels, otherwise really within normal limits. Cleared primarily for surgery at this point. And then this was her MRI of cervical spine. So just as you would assess in PA school, you learn how to assess a chest x-ray in an ABCD format. Same approach when it comes to MRIs. So x-rays are bones, MRIs are ligaments, tissues. This is a image that was cut in half throughout her body. So it's called the sagittal view. So you have the skin on the back here, the muscles, and then you have the bones with ligaments in there. Then you actually have the spinal cord, which is this dark black area. And then around the spinal cord, you have the white cerebral spinal fluid, which we make all the time in your brain and different parts of the brain. And it goes and travels down your spine and back up. Think of it like bubble wrap for your spinal cord and nerves. Then you have all the bones, one bone on top of the other, vertebral body. And then you look at the disc spaces. So these are the discs, the dark area. You see that this one is severely crushed. This one, again, degenerative changes throughout. That is not normal. You see her spine doesn't have really a normal curvature that's supposed to go in kind of a backward C. That's another thing to always note. And you want to see kind of how is the spinal cord affected? Is it clear, open highway, or is it kind of jagged? In this case, she has a lot of disc herniations here that are pretty significant at multiple levels, but she also has some light white area here that also is showing some type of spinal cord injury that will take some time to recover. The bottom picture here is, think of like slicing a loaf of bread, I should say. So one cut in front of the other, and it's pretty much mirroring one of these vertebral body sections. On the image, you'll have a localizer. So you'll just go one by one and you'll know exactly where the bone is with the disc. The spinous process is here, cerebral spinal fluid. And then usually you'll see black dots. Those are the nerves, and they always exit out of the foramen, which is Latin for basically a hole, essentially, that the nerves come through. And then you have, on this image, you have the MRI of cervical spine that had at C3-4 a disc bulge with central stenosis, meaning narrowing of the canal. And again, she had it at multiple levels. And again, you have the cord swelling from C3-4 through C5-6 right in here. Fun fact for cervical disc herniations, the intervertebral disc level most commonly affected is C5-6, then followed by C4-5, C6-7. So think of the spine, breakfast, lunch, and dinner, cervical 7, thoracic is 12, and then lower part of the spine, lumbar, is going to be 5, okay? Basic stuff. So final diagnosis is cervical spinal cord compression. What is the prognosis for these people? Well, very good. With proper surgical management, spinal cord swelling will improve over time. They'll be able to kind of go back into normal activity. It does vary of how severe the spinal cord injury was and how long the recovery is going to be. Without intervention, pretty much remains the same, but how significant her image was with positive physical exam findings, it will worsen and she can become permanently paralyzed. That's a big education for these patients. And then smoking is very important. We talked about her history already. Smoking inhibits bone growth, which makes it very difficult for the fusion to be long and lasting or effective if that's an approach that you want to take. So what's the treatment plan? We did all the labs. We said, hey, we're going to send her to an emergent C4-5 ACDF is the name of it. Neurosurgery is easy. You pretty much list out exactly what levels of the spine you're working on. And then she had a collar still, so we'll keep that. We'll monitor her a little bit overnight. We'll start and stop certain medications. We'll give her thiamine and folate, given the fact that she did have tremors on exam and still going through alcohol withdrawal. And then we would continue the medication she came in with, and then also provide some intervention for her COPD. And then she'll take all these before the surgery, the Tylenol, the Protonics, which really just helps with gastric motility, and then the steroid and antibiotic as well. Pretty common throughout. So lastly, this is the tail end of the presentation. This is the type of surgery that we did, ACDF, anterior cervical, right? We're in the neck, discectomy, means removal of the disc, and fusion, right? So now we're adding something, or we're allowing her bones to fuse. So when do we do this type of surgery? We do it to pretty much alleviate the spinal symptoms that are commonly caused by a multitude of things, whether they're bone spurs, in this case, osteophytes, spinal ligaments, or herniated discs. or even tumors. Honestly, sometimes you just have to remove the tumor, and it depends if you need to fuse after. And then the goal is to remove the damaged disc, particles, or whatever that's causing that compression. And some complications, like any surgery, right? This is important when you're getting consent from the patient. Infection, bleeding, spinal cord injury, strokes, cerebral spinal fluid leak is very important. That's something you always want to watch out for, especially when you're dealing with the dura that covers the nerves. People will have a massive headache. They won't be able to sit upright. It's a big ordeal. You would have to take them back into surgery and repair that. And then sometimes they can have postoperative hematomas, which is the bruising or, even swelling they can have, and that can lead to airway compromise, right? So there's a lot of tissue enlargement there. A good candidate is someone that is requiring an interbody fusion, that has really good skeleton formation and bones, and had undergone 6 weeks of non-surgical treatment. In this case, she doesn't have to do that, right? It's emergent. So these are kind of the benefits outweigh risk conversation. And then poor candidate is someone that doesn't have good bone quality, someone that has underlying medical conditions, sensitivity to implant materials. And for recovery time, patients stay overnight for monitoring and go home typically the next day. A day or two, depending on how they're swallowing and any other barriers that they might have. Maybe it's pain management that they're struggling with, or they need further care in an intensive physical therapy unit, or they can just go home and have PT come to their house. It all varies. And it takes about several weeks for bone fusion to heal. And max for spinal cord injury, it does take time and it depends on the severity. Usually the sweet spot is about 2 years. So the statistics, very commonly performed, 85 to 95% success rate in a 10-year prospective study. You'll learn this in PA school. It's all about evidence-based medicine. You'll learn why this is important. It's part of your patient education if there's questions asked. And then there was another type of comparison to cervical arthroplasty. Again, can be done through the front. And they had pretty good data as well. And then this part is most important. You have to, as a neurosurgeon, as a PA, whoever, should educate patients on the potential for developing adjacent segment disc disease due to an increased load on the adjacent vertebra. So when you're fusing, even the bones below it over time can become weaker, or the bones above it can also become weaker. So sometimes patients might need future surgeries in the long run, or they might have had multiple disc issues to begin with, and we can only work on one thing. And then what happens during the surgery? One, you go through the neck. Actually, a lot of people think it's always from the back. This one in particular is through the neck, usually the right side. We try to find a crease. And then that's when the anatomy comes into play. You need to know your esophagus, where's your carotid artery, your muscles, SCM, hyoid muscle, everything comes into play there, your actual clavicle bone, everything, thyroid cartilage. And once you finally take down and kind of create the space and approach of where you want to go, neurosurgeon stands on one side, you stand on the other. There's a huge microscope that goes over the person's body. Really cool stuff. It's magnified like 18 times. So it feels like you're actually in the person's body because that's how magnified it is. But you're actually working below with your instruments while looking through the lenses of the microscope. And that's when you're trying to remove any of the disc particles that were there or was pressing on the cord itself. And you'll see all of that, or maybe bones that you'll see also. And then what we did was we inserted an implant that actually had porous bone. So to conclude, this is how it works. It's pretty much a bone matrix that it's artificial, but it has certain products in there. Peak performance, bone matrix that provides osteogenesis, so the building of the bone, creating the bones, recruiting the bone cells to really start coming in and being able to fuse with the rest of the patient's bones in the spine. And it just allows a lot more of wicking ability, and it truly just allows the fusion to kind of go a lot more smoothly. And following surgery, you definitely don't want to give the patient an NSAID. You want to educate on no smoking, because you want what you just put in to really heal fully and truly visualize the site and see how it's kind of fusing together. So the findings for her was, during the procedure, the focus was to only work on the most problematic level. So that means we already knew we were going to see her in the future. After she heals from this surgery, we might have to do more because she had multiple pathologies. She had a difficult spinal anatomy. She had large herniated discs. She had severe spinal cord compression, with a few fractures that extended beyond what the image had shown. So again, only certain things you can see on the image. And then once you're in the surgery, you might see a lot more. The habitus might change. You might have to look deeper, or it might be right to your surface. So it does depend. Their BMI is very important. And then some of her disc particles were actually pushed under the ligaments so close to her dura. And again, we don't want to puncture the dura, because then that cerebral spinal fluid totally starts leaking, and we would have to basically put Duragen, and it glues that together. So you're working in a 2 millimeter of space. So imagine that you're having a microscope, you're only working in 2 millimeters of space. It's magnified 18 times. And you're implanting screws. So you're helping kind of navigate and using the instruments with the neurosurgeon. You're creating space for him or her, but you're also doing work on your side as well to control the bleeding and create more space and remove some disc particles yourself. So the pre-op images are really important. This is what she looked like before the surgery, and this is what she looked like after. So again, there's still some work that needs to be done, but primarily we really worked in this area right here. So it's no longer jagged and really puncturing that cord. And this is where that graft porous material is. So that's a good thing. But again, you always have to think of like, how bad is this going to be maybe a year or two from now in terms of how much load is on the neck? It's still straight. And that's not the greatest, but you do lose range of motion by 3 degrees per level. And every vertebral body you work on during surgery is about 2 hours long. So if it's a multi-level vertebral body, just times it by 2 every time. And then these are the post-op images. So this is after we put things. These are actually not her images. I did not get those specifically, but I wanted to show you 2 different types that neurosurgeons use. Some of them are very particular in what they use. Some neurosurgeons only use that peak technology that I showed before, where you just put that little cage in that takes place of the disc that you took out, and then you put the screws in front. Or some surgeons use the screws into the vertebral bodies. They never go into the nerves. So that's why they're always fixated to the body. This is a normal, good looking image. And then they put a plate in front of the screws. That's the type of style that my neurosurgeon likes to use. And sometimes he'll use this as well if a person had multiple surgeries. But the benefit of this is that usually the patient will wake up with very minimal swallowing complaint, versus this one, they'll always 100% complain of swallowing the first couple of days. It's like the worst. And you always want to think of airway compromise, because guess what's in front of this is your esophagus. So that's really important. And you might need to consult speech language pathology. You might need to consult a whole bunch of team members from different fields to really help with that patient following the surgery. So this was pretty much her hospital course. Not really much remarkable other than the fact that she did have some improvement in her dysmetria. Her weakness improved. That's the rewarding part of neurosurgery, is sometimes you can really see where they were before and how they are right after surgery. Where are they getting numbness and tingling back, or is it completely resolved and they can actually feel their hands, they can actually close their hands, they can talk in full sentences, they don't have that numbness from chest down. In her case, she still did, and that will take time. We don't know the timeline, but that's something to educate the patient on. And then overall, she did have some type of pneumonia at some point, aspiration pneumonia, and she was okay by post-op day 6. And then the follow-up instructions, kind of like, where is she going? Is she going home with this type of extensive surgery, or is she going to an intensive unit? In this case, she was going to an intensive physical therapy unit. where they're always there 3 hours a day working with her. She continued her home medications. And as a PA, you make that call. You have to understand meds. You have to understand what was she taking before? Does she need to still be on them? And then what new meds are you giving? Are you giving her narcotics? Are you giving muscle relaxants? How does that work? And when to have them take it? And then pretty much typical incisional site care education. Can they shower? Can they use soap? Can they submerge in bath water? Typically they won't be able to. Just let the water and soap trickle down. If they are taking narcotics, you're educating them on taking their medications to help them go to the bathroom. You don't want them to get constipated. A whole multitude of things that you need to educate your patient on. And then in this case, she did need to be in a collar. Most of our spine neck surgeries in particular do not require a patient to be in a collar. We want the muscles to be used. We don't want them to become stiff. So that's just neurosurgeon preference per se, but not every neurosurgeon follows that. And then typically they can't really drive until you see them again. So it's usually post-op. For my neurosurgeon, 14 to 21 days. Look at the incision site, see if it's healing appropriately. If not, you can put antibiotics. If so, you can take out the sutures or the staples or whatever that may look like. And then they'll follow up with new imaging 3 months from now. And then so forth as needed. Or if something else comes up, they can most certainly come in again. And no bending, lifting, or twisting for low back spine surgeries. And then for the upper body, like the neck, same concept, but definitely no lifting. Take your time, making sure you can swallow everything. And for her, it was no smoking for 2 months for sure. Ideally, we'd love for people to discontinue before they have this type of surgery. For others, it might be like, hey, don't smoke for 2 months and then you can have the surgery. And then we always look for signs of swelling. And then you also write in your discharge summary, who else do they need to see that's outside of your service? In this case, she needed to see a pulmonologist. She needed to see her PCP. She had various different past medical history outside of our care. And then again, just referrals as well. So patient education, lastly, what did I do? We had the preoperative MRI images and spinal models to pretty much explain to her, hey, this is what the spine looks like. These are all the components of the spine. This is what we're looking for on the image. This is what it's showing, the side, everything, angle, you name it. You can go as in-depth as you'd like. I prefer to be very transparent and honest with my patient and show them everything. And then I used pamphlets to just explain the fusion. And then I discussed the reason why we needed to have an emergency surgery, what to expect preoperatively and during surgery and then after, right? So some patients are like, oh my gosh, I can't swallow. Is this normal? Well, if you went over that with them before the surgery, then they should have the good expectations to know after surgery. So they shouldn't be alarmed, right? So that's a big part of a PA is to educate, or any medical provider should really be able to educate beforehand so that, you know, as a provider, you're not concerned either because you know the expectation. And then for her, it was the effects of smoking, how it inhibits bone growth. Motrin, same thing, any anti-inflammatories, we try to not have them on. And then prophylactically, we do want them to be on a blood thinner. But only for a very short period. They never go home on a blood thinner unless told otherwise. And then educated her on substance abuse. I used the teach back method, which just pretty much means that I'm asking if the patient understands and can they teach back the plan accordingly. And then if they have any questions, and I do that in clinic too, if they're a new patient and all of a sudden I'm like, you know, speaking with the neurosurgeon and collaborating with him later on in the week, and then I call the patient, or maybe I'm in the patient's room right away and I already tell them, hey, don't make a decision in a patient's office, in a doctor's office. Go home, speak with your family, take your time, write any questions you have. I threw a lot at you, kind of like I threw a lot at you guys for this case, but really just write down anything you need. And I typically don't talk this fast, so I apologize. But I do talk slowly with my patients. And that is the case review. So thank you for all those that were listening and joined in.
Thank you so much, Maria. That was a great case, very thorough. That's what one of the students said. They really liked it. You're getting lots of love in the chat. Love the amount of detail in this case study. Thank you. Thank you so much for really teaching the students, and especially for showing them the importance of patient education, taking the time to talk to patients to really understand their complaint, and also doing a thorough but focused history. So thank you so much. If any students have questions, we're a little over time. We'll answer 1 or 2 questions. If any students have questions about the case, we'll see if any students have, let's see, you're just getting lots of love. If I ever need a neurosurgery PA, I will be hitting you up. The bit about the microscope really helps pictures the way you work. Anything else to add there?
I think just ultimately understanding how to operate in an operating room as a team. You're not just there with your neurosurgeon, but you also have to be aware of all these other instruments that are in the room. And especially when the microscope goes over, it's completely sterilized. So you don't want to touch any part of the microscope that's not supposed to be touched. You have to understand like your parameters and how does every other team member function in that room, and you need to be respectful. It goes a long way. I'm a big proponent of that. So just really understanding that as soon as you're using the microscope, you're really focused, you're taking your time. If the surgery has to go over the typical limit, let it be. We're not there to rush. You're dealing with nerves, you're dealing with the 2 millimeters of space. And then when it goes over, you're back at it and doing a few more things.
Great. So we have 1 more question before you go. Tips for delivering difficult news to patients.
Yes. Okay. Big thing. And I really got exposed a lot more as a student too. So I'm very appreciative of that. But body language is something I can't stress enough. Regardless if you're telling them the toughest news of their life, you want to have great body posture. 99% of communication is through body language. That goes a long way when you guys are ready to interview for jobs, interviewing for PA school. You want to have kind of open palms, open stance. You don't want to be closed off. You want to be able to say the news with confidence, but at the same time, also be very cognizant of who's in the room, who's around you, what family members are in there. You don't want to use a lot of medical jargon. You want to take your time. You want to be confident in your assessment. If they have questions, by all means, stay, even if it means you're missing your next patient. That's how it goes, especially with patients that sometimes we deal with that have glioblastoma multiforme, and that's a pretty much death sentence right away when you see it on imaging. Never mind when you try to surgically intervene, if possible. Even that is a little bit tough. So body language goes a long way. And the one thing I will say as a whole throughout this profession, as you guys continue, is have faith for sure, whatever that looks like. Have support. Networking is your passport in life. So it gets you places. Put yourself out there, be persistent, understand that medicine will humble you every day. You're not supposed to know everything. So be a learn-it-all, not a know-it-all. And have a student of the game mindset, not someone that's just a fan of this profession, not someone that's just a fan of anything you care about. You want to research, you want to always grow and get better and be challenged and master what's called the boring stuff that people don't want to do. Okay. So that's my big takeaway of delivering tough news is be competent, be confident, but also really be sensitive, have emotional intelligence, cultural competency, and great body language.
Thank you so much. Somebody said great advice. And speaking of advice, Maria is a mentor on Medsembly. How I put the link there for you guys to connect with Maria, but are there any other ways for them to connect with you to, answer questions? I know you said you have your own platform as well.
Sure. I love Medsembly. I think it's excellent. I never had this type of resource. I think there's many resources out there to your disposal. It just could be almost over resourceful. So it is important to have a mentor. I think Medsembly does a great job with that. I have my own. It's called, I can put it in the chat, I guess, the PA Chronicles at gmail.com. I do a lot of free webinars. People have questions. I just kind of on the fly answer them through email, but I also have mentoring services as well that are very reasonable priced. So it's just called pachronicles@gmail.com for an immediate. And then I think this is my Instagram handle. I'm very like a one-to-one person, so I'm not on it as much, but I do check it daily. So I'm just happy that you have this as a platform. I'm very grateful. And I think it's really helping a lot of people, a lot of students for sure.
Thank you so much. So you kind of answered this already, but I always ask the guests to what's like one last takeaway. What's one thing you'd want the students to know? One piece of advice, one life lesson, just something for them to leave as they end the session.
Yeah, I love that question. That's so wholesome. The big thing I think I've learned for really at a young age, and anyone can learn this at any time, is have a servant leadership heart. You may not be able to fix everyone, you may not know everything all the time, but everyone can serve. Everyone can serve. So I'm really big on, giving more than it is expected, give more in value than you'd ever take in payment. Lend a hand. You never know who you're interacting with. You never know who's working with you on your team that's having a bad day, but serve other people. It's not about you. We weren't placed on this earth to just be selfish. We were placed on this earth to serve others and really have a servant heart with everything you do, because if you don't have a foundation, you fall for everything. So if you can start little by little every day and learning how to serve better and serve others, it's really going to come back and be a blessing in your own life as well.
Yes, thank you so much, Maria. Thank you. This session was incredible. Thank you. I mean, I can't believe you said you've only been a PA for 7 months.
Yeah, I'm learning a lot. No, 7 months.
I do not believe you.
I swear, look it up. Look it up. Look at my NCCPA ID.
You are so knowledgeable. That case study, I mean, I would have thought you were like, you've been a PA for at least 5 years from that case.
Oh my gosh.
So, thank you so much. You've been great. Somebody said TED Talk worthy.
Oh my gosh. I just want to make sure everyone got the email. I don't know.
Yeah,
I think you put it in, right?
Yeah, I posted it again for them. Hopefully everyone sees it. I posted it again with your IG, but thank you. Yeah. Thank you again, Maria. Have a wonderful night. Have a great night, you guys. Have a great week. Thank you.
You're welcome. Have a great night, everyone. Bye.